via the hospital, I'm not sure. I definitely don't feel alone. I definitely have the right people to contact, and I think if it wasn't the right thing, then I'd have been redirected. But it is an odd situation to be in, because I'm in that point at the end of my treatment where I'm at the most risk of recurrence, and yeah, I'm not really kind of under anybody. And I am obviously very anxious, and every time I get a symptom that's persisting, I clearly do want it checked. Um, but it is a weird time, and I think people don't always necessarily recognise how difficult this bit is. It's, for me, it's been the hardest bit. It's the bit that I've needed the most support in, is actually finishing the treatment and how I'm meant to carry on with life, but also manage the anxiety of recurrence, particularly because my cancer was very aggressive. And obviously that is a real risk for me.
Okay, thank you.
Thank you very much, Tracy. And that's certainly something I think for us to exactly think about when we're looking at those pathways. As we're looking at different ways of people followed up, and actually thinking about it, and obviously you really want to involve people like yourself kind of in that. I think if there aren't any more questions for Tracy, I'd like to again just thank you so much, and it's been lovely meeting you, and I'm sure we'll kind of meet you kind of on other meetings. And thank you for your time. So I know that actually you are a busy teacher, and you've kind of so kindly come in. I think kind of in between, kind of like doing kind of other stuff, and we're massively, and I really mean it, we're really massively grateful to you, and I hope all goes well for you in the future.
Thank you for listening. I do need to go and teach now, so I do
absolutely. So no, that's fine. Thank you. Thank you very
you.
much for coming. Thank you. Bye-bye. So now we'll move on to Marika and her team to talk and really does kind of follow on from this, I think, doesn't it, Marika, around exactly how we support, what we do for our patients, how we can make things maybe kind of better for them. And Marika's going to talk with a kind of whole host of kind of other people, and Marika within the kind of the team, and we didn't put them all on the well, Marika's got them all on the list here, to talk about the roles that are out there for kind of supporting and coordinating kind of care for kind of cancer patients. So I'll hand over to Marika.
Thanks, Suzanne. It's a shame Tracy couldn't stay for this part of the meeting, because I know there was lots of chat in the chat function, messages in the chat function, which Tracy may have found helpful. I know, Jenny, you would want to link in with her. So I think Sue's already said that she will support on that, and obviously I will too. So my name's Marika Pieri. I'm Cancer Transformation and Workforce Project Manager at the ICB. But this is very much a joint presentation, and I will let everyone else introduce themselves as they do their own slides. So if you can move to the next slide, please. This was actually a presentation that we had prepared for our regular Cancer Care Navigator meetings. These are regular working group meetings that we have. And we had a couple of questions about how personalised care is delivered in primary care. And we started to look into that. And one of the things that we were going to look at is the roles of how personalised care is delivered in primary care, how the roles differ between those in primary care and secondary care, and how many there are. So that's what we're going to be looking at today. And also, some of this information may already be familiar to you, and hopefully it will, but it's also initiating that piece of work where we're strengthening those relationships between the two sets of roles, so that we can work more seamlessly together. And hopefully that will help people like Tracy's story about only telling the story once. Hopefully we can sort of look at the pathways to improve that. So we'll also be looking at the additional roles reimbursement scheme in primary care, how the PCNs are using additional transformational funding for learning to support cancer care coordinators, health wellbeing coaches, and admin roles. And we'll be looking a little bit around the Cancer Care Navigator roles. We've got someone here who'll be explaining their role in secondary care. I think we've got Emily here as well, I'm not quite sure, to talk about the evaluation of the James Paget service. And we'll also be discussing some of the training that's available to cancer support workers. So next slide, please. So I think this slide is Vicky's.
Sorry, I don't come in. Okay. So we as well as the cancer care coordinator roles within hospitals, we were looking to extend that offer potentially to primary care. And this was, after a sort of bit of consideration with the localities, we were thinking about sort of a flexible offer, because we recognise that one size really doesn't fit all. So I think further on in the presentation, we'll be looking at the different models proposed by the localities, and how we can use that to kind of upskill is a horrible term, but upskill in terms of cancer, the roles already existing and people already involved within administration and the 2-week wait referral process and what have you, to be that connector between primary and secondary care. There's lots of training, as we've discovered. I'm sure Marika will touch on the amount of training that's actually out there once you actually start digging around for what's available. And then also looking at support forums, how we can best support people who are involved in pathways, and and how we can make sure that people, we don't duplicate what's already out there. So I think that's my opening gambit for care coordinators in primary care.
Thank you, Vicky. So I think the next slide is about the additional roles reimbursement schemes. So this was something I wasn't really familiar with when I first started looking into this. And it was to support the PCNs, providing funding for around 2,600 additional roles to create bespoke multidisciplinary teams to deliver health services. And we're going to look at the 3 roles in particular later on, but these staff, the terms and conditions around it, with the staff were to be in addition to the baseline of general practice taken at the 31st of March 2019, hence they were called additional roles. So each PCN was allocated an Rs budget for the year based on its population size, and staff are paid by the PCN or practice, who will then be reimbursed through the scheme. And the funding cost covers salary and on costs. And some of these on costs can be up to a maximum reimbursement amount and can be anything ranging from laptops, uniforms and travel. So the roles that we're going to be looking at through the R scheme are care coordinators, health and wellbeing coaches and social prescribing link workers. And I believe we've got Claire next to tell you the differences between those 3 roles. Oh no, we haven't. It's just my slide again. We've just got one more, which gives us around the numbers of care coordinators for Norfolk and Waveney PCNs. So the table shows the whole time equivalent, which were in each PCN as at January 2023. Just to note, there could be some slight discrepancies. And we've included this slide because we were asked to confirm how many of the roles there are by practice. But as these roles work by PCNs, that work across as PCNs, not by practices, we weren't able to provide that information at that level of detail. The one thing to maybe note is that Norwich PCN has a higher number, and that's because its population size is equivalent of 4 PCNs, and this would explain why there is a higher number of care coordinators in that area. Right, I think the next slide is now Claire just explaining about the 3 different roles.
Thank you, Marika. Can everybody hear me okay? Because I'm in a very new environment.
We can hear you.
Thank
Yes.
you. So this diagram shows the 3 different roles, as Marika's already described, with a few exceptions. There are a few exceptions about roles, although predominantly recruited through the primary care networks through NHS funding, as already described. They are also employed in voluntary sector and local authority settings where contracts have been agreed. The roles interact with each other dependent on the person's needs. A what matters to you conversation occurs with all of these roles, and as a discussion between equal partners, also known as co-production, with the person. So just like Tracy. So the Tracy and the professional, the social prescriber, the health wellbeing coach, the care coordinator, would have a two-way equal partnership discussion around how that person wants to live, what is preventing them from getting to their vision and aspirations of how they want to live, and what support can be put in place to make those aspirations a reality. So really important conversations that are happening. It's the first time that someone has generally been asked to think about how they would like to live their lives and what matters to them. And I think that was quite evident in Tracy's example a moment ago of her own experiences. So why does it matter to them, and how to have conversations about barriers they may face, or what they could support what support they require to overcome those barriers. So some individuals may be very clear about what is important to them, and others may need support and time is really key to think this through, especially if they have never accessed care and support in the past. Next slide, please. Sorry,
This is you
I'm on
again,
a time
Claire.
delay. Yeah,
Yes,
I'm on a
sorry.
time delay. Apologies. So these are the three roles, and there's just a definition of what they are. They are there to support our populations with. So care coordinators provide extra time, capacity, and expertise to support patients in preparing them for clinical conversations or in following up discussion with primary care professionals. Supporting on prevention, screening, safety netting, early diagnosis, and most importantly, personalised care. They can also help patients navigate the system as a very stressful time, which again, I think Tracy alluded to. And patients want consistency with whom they speak to, and having a care coordinator involved can help with this. This role can also link patients to other members of the MDT, so the multidisciplinary team within the health sector that may be of assistance earlier on in the pathway. And I think that's where we've already identified those gaps. Health and wellbeing coaches predominantly use health coaching skills to support people to develop their knowledge, skills, and confidence to become active participants in their own health and care. So that they can reach their own health and well-being goals and those aspirations. This may also provide access to self-management, peer support, and a further referral on to social prescribing. So social prescribing link workers give people time and focus on what matters to them, as identified in their personalised care and support plans. They connect people to community, groups, agencies for practical and emotional support, and offer a holistic approach to health and well-being, hence the name social prescribing. Addressing issues such as poor housing, financial concerns, stress, loneliness. There's not much a social prescriber isn't able to support somebody with, but it's not just the person, it's their entire family network. And then next slide, please.
I'd like to introduce Philippa now to talk about the care coordinator role.
Hello everyone, I'm Philippa. I'm based within the Mid Norfolk PCN as one of the team of care coordinators. I'm mainly based at Theatre Royal Surgery, and we play an important role with proactively identifying and working with groups of people such as the frail, elderly, vulnerable. We will look at things like admission, discharges, and if we feel that people have come out and haven't necessarily got or we can't see what package of care they've got, we will call them and try and be proactive in organising some additional support and care for them. And then, as I say, we work with the health and wellbeing coaches and the social prescribers. So again, the GPs quite often will send us tasks sort of saying, well, refer this person to the social prescriber or the health and wellbeing coach, and we'll talk to those people and we'll refer them to where they need the most support and where they'll get the support from. So we kind of give extra time, capacity and expertise to try and support those patients. We coordinate the multidisciplinary team meetings and minute and code these on the patient's record so that they are picked up when reports are run, so we can follow them up. And we can work with different groups of people. So one project we've been working with was within informal carers, where we made sure that we had the correct list of informal carers, and then we have started contacting them in cohorts and offering them sessions with the health and wellbeing coaches to try and support them moving forward, because they are doing an important role and need that additional support, whether, which they might not have thought of for themselves. As I said before, we try to be more proactive. So we are again identifying patients as they come out of hospital. If we know they've got falls and are particularly vulnerable, then we obviously contact them and get them more care and support and check in on them and make sure they are okay. With regards to cancer care, I'm involved where for their 12-month cancer care review, a letter goes out from myself asking them if they'd like an appointment with the GP face-to-face on the telephone. And with that, and they can send that back in, and then I will ring and arrange that appointment. With that, they also get a concerns checklist, be it physical concerns, emotional concerns, practical, spiritual, family or relationship information and support. So I can make sure the GP is aware of the ones that he or she needs to be aware of, and then anything else I can refer on to other people that can support, or I can signpost the patient to where they might get more support from themselves. So I think that's most of what I need to cover, I think. Is that okay, Marika?
Yes, thank you so much, Philippa. That's
Thank you.
really helpful to hear. And I think we have Jenny next to talk about health and wellbeing coaches and her fellowship.
Yeah, good afternoon, everyone. I'm Jenny. I'm a health and wellbeing coach working in Mid Norfolk, so covering 6 practices across Mid Norfolk PCN. So, like Claire and Philippa have just shared, really, it is about considering the whole person. I think patients love kind of having a listening ear, you're finding out what makes a difference to them, like we heard from Tracy earlier. So we will address existing issues, but also encouraging the patient to be proactive to prevent any new illnesses that might come up, up in the future. So at Mid Norfolk, we offer 6 to 8 appointments. Some patients have slightly more than that, some have slightly less, but we offer those on a one-to-one session. But we can offer deliver group sessions as well. So that might be a focus on healthy eating. It might be stopping smoking, reducing alcohol consumption, increasing and helping patients to get started with physical activity to generally improve their well-being. Sometimes patients will bring their relative with them as well. So if it's somebody that does the cooking in the household, or generally they need the support of somebody else, then they will bring that person to the appointment as well. So it is about motivating patients and coaching them. I think sometimes we get into conversations about, well, what do you think I should do? So it's quite nice to say, this is your life, and really getting into that patient's shoes and listening to what makes a difference for them, and finding out what the barriers are as well, and hearing about those appointments, seeing somebody change from appointment number 1. I always say sometimes it'd be great to kind of record them at appointment number 1 to appointment number 6 or 8, because the difference can be amazing. So we're also increasing the patient's ability to use and connect with community supports. So for instance, I've had a gentleman referred who really struggled with the cost of living crisis, and really took on board using the mobile food store and things that moves around the Breckland area, and that made a difference to what he was eating, but also the anxieties and worries about the cost of food as it increases at the current moment. So yeah, again, that's about self-management education, again, connecting them with local groups, and the social prescribers are also a great resource that we've got as well. So I'd like to think, an integral role into general practice, and there's 2 of us currently in the role as health and wellbeing coaches, but we do cover face-to-face appointments across the PCN to give a wide range of where we are, and that allows us to work really well with the the rest of the R's roles, so the care coordinators, lucky to work with a great team of those, the social prescribers that are at Brecon Council, and as well as the community health nurses, the physios and the clinical pharmacists. And we will welcome referrals from any of those, as well as the GPs and the nurses in all of the surgeries. Next slide, please. And then I just wanted to share with you my other hats. So I worked 4 days as a health and wellbeing coach, and I was lucky to secure a fellowship in November to work with the ICB to focus on personalised care with a specific interest in cancer care. So I am gutted that Tracy's had to go, and I will catch up with her at another time. I feel really privileged to do this role for a year, as it is the first non-clinical role to be awarded a fellowship nationally. So I know that Claire has informed me that NHS England are looking at this very closely, so we are working on that. So I'm using my role as health and wellbeing coach and my own lived experience of breast cancer to support patients who have finished cancer treatment or are newly diagnosed to improve their well-being and access to social prescribing services. We're developing working relationships with the oncology teams in the local acute trusts, as well as working alongside the cancer care navigators and the cancer care coordinators at primary care. The aim is to provide strong links between primary care and the acute trust. I think we've heard earlier from Tracy and from my own experiences that we want to kind of have a joined up approach there. And we're especially working with Elmham surgery, which is one of the surgeries in the PCN, to pilot how we can make that happen and picking up patients early. So at the moment we are having a new cancer diagnosis meeting, which I'm attending, and then making contact with patients that perhaps just about to start treatment to find out how we can support them, and also to pick them up as they kind of approach the end of treatment, whether that's for palliative support or improving the way the cancer care reviews are done. So if you're in your PCN, you'd like to get involved and hear more about my fellowship, then my email address is on there, and I'd love to hear more. I'm really enjoying connecting with everybody. Thank you very much.
Thank you, Jenny, for your time as well.
That's all right.
That's really helpful. And I think we're being mindful of time, so I'm going to pass on to the next slide, which Vicky's going to give a very quick summary around some funding for training.
Watch me go zoom on this. Okay, so previously mentioned, we talked about the primary care cancer coordinators. There are different models that were suggested, and the next slides really are the 5 locality suggestions of what they could do with that potential funding to support the bridge between primary and secondary care, and help us with the sort of the cancer pathways, and also to signposting to social prescribing and what have you. So I think we can fly over this like a seagull over the wash, and away you go, keep going. And it depends on it all really depends on how the localities wanted to use that funding. So I think as this is recorded, you'll be able to see that there's so there is differences, but for a very good reason.
Yeah, and we'll be circulating the slides after the webinar as well. But
Yes.
if we can now introduce Jane, because we're going to be shifting the focus now to secondary care, and Jane will tell us all about the cancer care navigator role.
Hello everyone, nice to see you again. I've worked within the trust for about 18 years now in different roles, but mainly involved with cancer. I started the role as a navigator last February, which has gone really quickly, working alongside a team of 3 other navigators. It was a bit of a slow start, and we carried out various trainings such as different modules with Macmillan, Sage and Time course you might have heard of, and visiting all the local support centres such as the Big C and Tapping House Hospice local here. So we spent time also in different support groups, which was very enlightening, and lots to learn at that time last year. It's taken up some time to build up relations with some of the clinical teams, but I think we're practically there now. So having regular catch-ups and communication and how we can move forward and improve our service even more. We carry out the holistic needs via the telephone, and we offer face-to-face appointments, which we're trying to increase. Holistic needs assessments are offered to patients with a cancer diagnosis and beyond, offering physical, emotional, practical, financial, or any spiritual concerns. Really feel quite passionate about job. Each day is very different. We can be on the phone from 10 minutes to 90 minutes or even longer, chatting to a range of different patients with different needs. Had a patient this morning with bladder cancer, lovely lady, 85. She's got a back injury and also macular degeneration. So, so for her, probably after doing the HNA, we will do a follow-up call to see how she is. So as a navigator, we signpost to different support centres. We have an on-site wellbeing support centre here. We're lucky enough to have that. We offer Reiki, reflexology, mindfulness, light exercise regime class, and also a very popular cuppa support group once a month. And Look Good, Feel Better calls for patients. That's quite popular. We also contact the patient if they would like a follow-up at any time. We can repeat the holistic needs, which we will do quite happily. And in the last month, I've started to co-facilitate the Hope course here at our Wellbeing Centre. So really enjoying that, meeting patients on a face-to-face basis. So yeah, really enjoying that. So yeah, one year on, still feeling as passionate and really enjoying the work here at Queen Elizabeth. And again, like Jenny, like to catch up with Tracy at some point.
Yeah, that would be great. Thank you so much, Jane. I want to say thank you for everyone for their time, because I know we're running out of time and people might need to leave. But the next slide is Emily, and she will be giving an update on the James Paget evaluation of the CCN service, Cancer Care Navigator service.
Yep. Hi, everyone. Yep. So I'm part of the evaluation team at the ICB. And yeah, as Marika's just said, I'm just going to talk through a one-slide summary of this evaluation that we completed earlier in the year. So the first section on the slide has a bit of background on the Navigator service at the James Paget. The second section sets out the aim of the evaluation, which was to assess the introduction of the new service, and the objectives go in a bit more detail about what we wanted to explore and what data we collected for each objective. I'll just move on to the main section, the third section, which is a summary of the findings from the evaluation, which took place in the first 7 months of the service. So starting with the CCN activity, the team reported 1,071 interactions with patients in that time, and that included repeat interactions with the same patients. And as you can see from the graph, the number of interactions increased each month from when the service went live. The navigators also provided us with 4 anonymous case studies for the evaluation, and these were about patients that they supported, and they explored 3 main areas. The first was sort of setting the scene and the initial situation of patients who were often struggling with their cancer diagnosis and felt unsure about who to contact. The second section was the case study explored the support and signposting that the navigators provided, and that included listening to patients and regularly contacting them. And then the third section was the impact that the navigator involvement had on patients' well-being, with patients saying that the navigator support helped them to move forward. Just moving on to the patient experience, we analysed responses to the survey, and we found that overall patient feedback was positive, and patients gave examples of what had gone particularly well. For example, regular phone calls and also receiving practical and financial advice from the navigators. We also carried out a focus group with the navigators. During this, they described how they joined the team with the aim of delivering a patient-led service that was focused on putting patients at the centre. And then finally, the the CNS survey. 5 CNS completed our online survey about the new service, and they agreed that the navigators had supported them, for example, with signposting patients, and also that the service was a valuable resource for patients and their families. So this was just a very quick summary. This is based on an evaluation report. Also, the QE and NNN Navigator evaluations are in progress, and I'm happy for anyone to get in touch later on with any questions. Thank you.
Thank you, Emily. And it's really great to see how well the service is doing and to have such lovely feedback already. So it's brilliant. Thank you. So moving on to the next slide, I think it will be Sue talking about the Cancer Care Champion Awareness Training.
Hello everyone, I think most people know me, but if you don't, I am the Cancer Transformation Team Project Officer, and I also the Patient Experience Lead. This Cancer Champion Awareness Training is really good. I've attended it. And it's not very long, which is great. So it's only an hour and a half, which is very informative, and you get a free little cancer pin badge as well for your lanyard. So all the information is on the slide. There's still dates. I checked for tomorrow. There is still 3 dates that you can attend. So if you go on the link, it shows you all the training information, and you can sign up for the training. It's all virtually. They are going to be holding some face-to-face sessions. You don't need any qualifications or any specialised knowledge of the cancer is required. So the sessions are there to teach, key facts, statistics, symptoms and screenings linked to a number of cancers. So which is really helpful. And they do a second part as well, which I'm going to do, which goes into cancer a bit more. So becoming a cancer champion can help and encourage early diagnosis and improve outcomes for people affected by cancer. So yeah, so obviously check it out. You may know of it or have done the training, but if you haven't, and share it with people in your field. So yeah, that's about it, I think.
Thank you, Sue. We're just going to move on to the next slide. I'm running out of time, so I'll just quickly go through this, which is about the Cancer Academy, which is hosted by Cheshire and Merseyside Cancer Alliance, which provides a collaborative platform. And that's been collaborated with healthcare, charities, social care and voluntary sectors to create this high quality resource to improve knowledge and confidence around cancer related matters from prevention to treatment. So there's links there with further information, and if you have any other questions, please let me know. The next slide is back over to Claire about Gateway C.
Thank you, Marika. So I'll also be quick. So Gateway C is a free online cancer education platform, which many of you may be aware of. It is fully funded by Health Education England and developed for primary care professionals across England. It aims to improve cancer outcomes by facilitating those early diagnoses and improving patient experience. So I won't carry on. Go and have a look. There are so many modules that you can complete on there that will support your own CPD, professional development, understanding, that I can't recommend Gateway C enough.
Thank you, Claire. And I think the next slide is some education for non-clinical staff. So O'Halloran Consultancy have been funded by the East of England Cancer Alliance to provide a schedule of education that covers the science of cancer. And there's information there on the slide on how you can register. It's available for 1 year, and the program will rotate throughout the year and will be delivering hour-long interactive webinars. So again, if you want any further information, the slides will be circulated with those links. Okay, and then the next slide is about health inequalities and cancer care training. So this has been commissioned by Health Education England and is a pilot, the East of England Health Inequalities and Cancer Care Programme. It's